Welcome back to the deep dive. Today, we are really focusing on something critical in pediatric care. We're looking at alterations in gas exchange and respiratory disorders in children. Our sources are very clear on this.
They are.
Respiratory problems, they're the number one reason kids get sick and end up in the hospital.
That's absolutely right. And for you listening, getting a handle on this material isn't just helpful, it's vital.
Right.
So our mission today is really to sift through all the details and pull out the key things, the assessment findings, the anatomy differences, the interventions that, really make a difference.
Okay, so let's start with the basics.
Yeah.
Gas exchange. When we say a respiratory disorder compromises gas exchange, what's actually breaking down?
Fundamentally, gas exchange is getting oxygen to the cells via the bloodstream and then taking the waste product carbon dioxide away from the cells.
Simple enough in theory.
Right, but when a child struggles to breathe, that whole balance gets thrown off. And here's the key thing. Unlike adults, their little bodies are kind of set up to decompensate faster.
Built to fail faster. That's a stark way to put it, but it really hits home. And that's where we need to focus first, right? The differences in anatomy and physiology.
Exactly. These aren't just minor tweaks compared to adults. They explain why, say, a simple cold can be much more dangerous for a toddler than for you or me.
So what are those key differences we absolutely have to keep in mind?
Okay, we'll start with the nose. Newborns are what we call obligatory or preferential nose breathers. For at least the first 4 weeks, maybe longer.
Meaning they pretty much have to breathe through their nose.
Pretty much, yeah. They don't automatically switch to mouth breathing if their nose gets blocked. So think about it, the simple nasal congestion. It can immediately cause problems with feeding, make them distressed.
Because they can't breathe and eat at the same time if their nose is blocked.
Exactly. So that simple stuffy nose suddenly becomes a much bigger deal.
Okay, that definitely raises the stakes. But the structure, lower down on the airway, that's where the real danger lies, you mentioned. The size difference.
Oh, absolutely. The actual numbers are, well, they're pretty striking. An infant's trachea, the windpipe, it's only about 4 millimeters wide.
4 millimeters. Tiny compared to an adult's.
An adult's is around 20 millimeters. Now, here's the number you really need to remember. Just 1 millimeter of swelling all the way around that tiny airway. That single millimeter cuts the diameter in half. A 50% reduction.
Wow, 50%. From just 1 millimeter.
But wait, the impact on airflow is even more dramatic. That 50% diameter reduction, it increases the resistance to airflow by 16 times.
16.
16 times the effort needed just to push air past that swelling.
Okay, now I see why something that's just a sore throat for an adult can become a full-blown emergency for an infant.
Precisely. It can lead straight to stridor, difficulty breathing, even respiratory failure.
And it's not just the size, it's the shape too, right? The larynx.
Yes, exactly. The infant larynx is shaped more like a funnel. It's because the cricoid cartilage isn't fully developed yet. Adults have more of a cylinder shape.
And a funnel shape is less stable.
It's more prone to collapsing. Makes them more susceptible to upper airway obstruction. And then add the chest wall. It's really soft and compliant in infants and young children.
Compliant meaning flexible.
Very flexible. Too flexible, really. It doesn't provide good support for the lungs.
So when they work hard to breathe, their chest wall actually gets sucked in.
Exactly. You see those retractions. And it means their breathing, their tidal volume, the amount of air per breath, becomes almost completely dependent on their diaphragm.
Okay, so if the diaphragm gets tired or if their belly is distended for some reason.
They lose their ability to move air effectively. Very quickly.
And one last piece, their metabolism.
Right. Higher metabolic rate. They just burn through energy faster than adults.
Which
means they have a much higher demand for oxygen. So when things go wrong, when they're in distress, they use up their oxygen reserves and become hypoxemic, low blood oxygen much, much faster than an adult would.
Seconds versus minutes, potentially.
Potentially, yes. It underscores why quick, accurate assessment is just non-negotiable.
Okay, let's pivot to that assessment. If a child is starting to struggle, what's the absolute first sign you're going to see?
Tachypnea. A fast respiratory rate for their age. It's the body's first way of trying to compensate. Earliest, most reliable sign.
Got it. Fast breathing.
But here's the crucial warning, the thing you cannot miss. If you see an acutely ill child whose breathing is slowing down or becoming irregular.
That sounds counterintuitive. Wouldn't slowing down be better?
No, it's an ominous sign. It means they're exhausted. They've maxed out their ability to compensate, and respiratory arrest could be imminent. That slow rate is a red flag.
Okay, crucial point. Beyond the rate, we look at the effort, the work of breathing, or WOB. What tells us they're working too hard?
You're looking for accessory muscle use, so nasal flaring, the nostrils widening with each breath, and retractions, that inward pulling of the soft tissue.
And where the retractions are matters.
It does. You need to note the location. Is it suprasternal, above the sternum, supraclavicular, above the clavicles, intercostal, between the ribs, subcostal, below the ribs, substernal, below the sternum?
Is there a pattern to severity?
Generally, the lower down the retractions are, the milder the distress. But seeing retractions anywhere means increased work. And if you see paradoxical breathing, that seesaw motion where the chest falls while the abdomen rises, that's highly ineffective breathing. Big trouble sign.
Okay. What about color? We always hear cyanosis is bad, but it's a late sign.
Central cyanosis, yes, that blue tinge around the lips, on the tongue, the core mucous membranes, that's definitely a late sign of low oxygen.
But newborns often have blue hands and feet, right?
That's right. That's acrocyanosis, and it can be perfectly normal in a newborn. You need to distinguish it from that central blueness. Also, watch out for pallor, paleness.
Paleness. Why is that significant?
It often means the body is shunting blood away from the periphery, trying to protect the core organs. It's another sign of significant distress, peripheral vasoconstriction.
Got it. Now, the sounds. What are the key sounds we need to listen for, and what do they tell us?
Okay, key sounds. First, stridor. That's a high-pitched noise usually heard when they breathe in.
Inspiratory?
Yes. And it points to upper airway obstruction, something going on in the larynx or the upper trachea. Think croup.
Okay. And wheezing?
Wheezing is also high-pitched, but usually heard when they breathe out.
Expiratory.
Right. That signals lower airway obstruction down in the smaller bronchioles. Think asthma or bronchiolitis.
And that little grunting sound some kids make.
Grunting happens on expiration, too. It's the body's clever, though concerning, attempt to keep the tiny air sacs, the alveoli, open. It's trying to maintain some air in the lungs, what we call functional residual capacity, or FRC.
So it's like they're trying to splint their airways open.
Exactly. You often hear it with things like pneumonia or atelectasis, where alveoli are collapsing or filled with fluid. And speaking of fluid, if you hear riles or crackles...
Like cellophane crinkling?
Sort of, yeah. That usually means there's fluid inside the alveoli themselves. Pneumonia is a classic cause.
Okay, those are the acute sounds. Is there anything we look for physically that indicates a chronic respiratory problem?
Yes. Clubbing of the fingers. It's this enlargement and rounding of the very tips of the fingers, the terminal phalanges.
And that means?
It's a sign of long-term chronic hypoxemia. The body is trying to adapt over time to low oxygen levels.
Okay, so physical assessment gives us a ton of information, but sometimes we need tests to confirm things. Pulse oximetry is standard, checking oxygen saturation non-invasively.
Right, essential. You'll often see the SpO2 drop significantly in distress.
What other diagnostics are common?
Chest x-rays are very common. They can show us things like hyperinflation, like you see in asthma sometimes, or infiltrates suggesting pneumonia, or atelectasis, which is collapsed lung tissue.
And identifying the specific bug, especially with viruses.
Crucial. We often do nasopharyngeal washings. We collect secretions from the back of the nose and throat to test for specific viruses, especially RSV, respiratory syncytial virus.
How do they test that sample?
Usually with rapid tests like ELISA or IFA. Knowing if it's RSV, for instance, impacts isolation precautions and gives us an idea of the potential severity.
And for chronic conditions like allergies or CF?
For allergies impacting breathing, like an allergic rhinitis or asthma, allergy skin testing or blood tests like RS can help pinpoint the specific triggers. Knowing the trigger is key to managing it.
Avoidance becomes part of the treatment.
A huge part. And for cystic fibrosis, the gold standard diagnostic test is the sweat chloride test.
Right. Okay, that covers assessment and diagnostics well. Let's move to interventions. Thinking about those priority nursing diagnoses, airway, breathing, circulation. Let's start with ineffective airway clearance. How do we physically keep that airway open?
Position is key. For infants, the sniffing position, head slightly extended, neck slightly flexed, helps align the airway structures if they're lying down.
And for older kids, or just generally?
Elevating the head of the bed is usually helpful. Uses gravity to ease breathing and helps drainage. Humidification is also important. Moist air helps thin out secretions, making them easier to clear.
And if they can't clear secretions themselves?
Suctioning. Yes, but carefully. Whether using a bulb syringe for the nose or a catheter for deeper suctioning, you have to be quick and gentle. Limit suction attempts to no more than 5, maybe 10 seconds max.
Why the limit?
Because you're potentially removing oxygen along with the secretions, and you can cause trauma or vagal stimulation, which could slow the heart rate, minimize risk.
Good point. And what about feeding? If a child is breathing really fast, that tachypnea we talked about.
Big aspiration risk. If their respiratory rate is significantly elevated, they need to be NPO, nothing by mouth.
To prevent choking or aspirating fluids.
Exactly. Safety first. Their energy needs to go into breathing, not coordinating sucking, swallowing, and breathing all at once when they're already struggling.
Okay. Moving to impaired gas exchange, the goal is better oxygenation. That often means giving oxygen. Any key rules there?
Oxygen is considered a drug, so you need an order. And critically, especially for kids, it must be humidified.
Why is humidification so important?
Dry oxygen is incredibly irritating to their delicate nasal passages and airways. It can cause dryness, cracking, nosebleeds, increase inflammation, and just make them miserable, which then makes them fight the oxygen delivery device.
Makes sense. Humidify it. And the delivery methods?
Depends on how much oxygen they need. Could be a nasal cannula for lower amounts, a simple face mask, or a non-rebreather mask for higher concentrations.
And medications play a huge role.
Okay.
Let's talk about the difference between rescue and controller meds, especially for asthma.
This is so important for families to understand. Rescue medications are the short-acting beta-2 agonists, like albuterol or levobuterol. They work quickly to open up constricted airways during an acute attack.
Quick relief.
Right. Controller medications are for long-term management. This includes inhaled corticosteroids, which reduce the underlying inflammation, and sometimes long-acting beta-2 agonists, like salmeterol.
And the crucial difference?
Long-acting beta agonists are not for acute attacks. They take longer to work and don't address the immediate bronchospasm. Using them instead of a rescuer in an emergency is dangerous. They're for daily maintenance alongside an anti-inflammatory, usually.
Got it. Rescue for emergencies, controllers for prevention, and one more safety point, we have to mention the aspirin risk.
Yes, absolutely critical. Never give aspirin or salicylate-containing products to children or teens, especially if they have a fever or are recovering from a viral illness like chickenpox or the flu.
Because of the risk of Ray's syndrome.
Exactly, a devastating illness affecting the brain and liver. Acetaminophen or ibuprofen are the generally recommended fever reducers for kids. Constant family education on this is needed.
Okay, let's tackle some specific conditions. Starting with 2 high-stakes acute upper airway problems, croup versus epiglottitis. How do we tell them apart?
They can both cause stridor, but they are very different beasts. Croup, its proper name is laryngotracheobronchitis, is usually viral. Parainfluenza is a common culprit.
And who gets croup typically?
Usually younger kids, like 3 months to 3 years old. It often starts suddenly, frequently at night. The defining feature is that horrible seal-like barking cough and hoarseness. Fever can be variable.
Management for croup.
Often supportive. Cool mist can help sometimes. For moderate to severe cases, we use corticosteroids to reduce swelling and sometimes inhaled racemic epinephrine for temporary relief. Many kids are managed as outpatients.
Okay, now contrast that with epiglottitis.
Epiglottitis is a true medical emergency. It's usually bacterial, classically Haemophilus influenza type B, though less common now thanks to the hive vaccine, but other bacteria can cause it.
How does it present differently?
Rapid onset. The child looks sick, toxic, high fever. They're often drooling because it hurts too much to swallow saliva. And critically, they usually refuse to lie down.
Do you sit up?
Yes, classically in that tripod position, sitting up, leaning forward, neck extended, sometimes mouth open, trying to keep their airway maximally open. And importantly, the barking cough of croup is usually absent.
Okay, it looks very different. And the absolute #1 nursing priority if you suspect epiglottitis.
Do not, under any circumstances, attempt to look in their throat. Don't use a tongue blade. Don't try to get a throat culture.
Why not?
Because stimulating the inflamed epiglottis could cause a complete sudden airway obstruction due to laryngospasm. It's incredibly dangerous.
So what do you do?
Keep the child calm. Let them stay in their position of comfort, often on the parent's lap. Avoid any procedures that might make them cry or agitated. Keep oxygen nearby, and prepare for emergency airway management, often intubation in the operating room. Sometimes even a tracheostomy might be needed. Get expert help involved immediately.
Life-saving distinctions there. Okay. Shifting gears to chronic conditions, let's talk asthma. We know it's inflammation, but there's this concept of airway remodeling. What's that about?
Yeah, that's a key part of our modern understanding. Airway remodeling refers to permanent structural changes that can happen in the airways over time due to repeated inflammation and exacerbations.
Like scarring.
Sort of. thickening of the airway walls, increased mucus glands, changes in the smooth muscle. The end result can be a permanent loss of lung function, even when the asthma seems controlled. It highlights why consistent, long-term control is so vital.
And how is that control managed? You mentioned controllers earlier.
Right. The core approach is stepwise management. Based on how well controlled the child's asthma is, their symptoms, nighttime awakenings, rescue inhaler use, activity limits, we step medication up or down.
It's tailored and adjusted over time.
Exactly. The goal is to find the lowest level of medication that maintains good control. Long-term control usually relies heavily on inhaled corticosteroids to manage that underlying inflammation.
And how do families track control at home?
The asthma action plan is key. It's a written plan developed with the provider that tells the family exactly what to do based on symptoms or peak flow readings.
Peak flow meter that measures airflow.
Yes, peak expiratory flow rate. It measures how fast the child can blow air out. The action plan uses zones, usually color-coded like a traffic light.
Green, yellow, red.
Right. Green zone means good control, continue routine meds. Yellow zone means caution, asthma may be worsening, often involves increasing meds or adding the rescue inhaler more regularly. Red zone means medical alert. Use the rescue inhaler and likely seek urgent medical attention. It empowers families to manage proactively.
Okay, great overview of asthma management. Finally, let's touch on cystic fibrosis, or CF. It's genetic autosomal recessive.
Correct. Caused by a defect in the CFTR gene.
And the main problem is thick, sticky mucus.
Incredibly thick, tenacious mucus. It affects multiple body systems, but the lungs and pancreas are hit particularly hard.
So what are the absolute cornerstones of managing CF?
There are several, but two huge pillars are airway clearance and nutrition.
Airway clearance first, what does that involve?
Because that thick mucus clogs the airways and traps bacteria, leading to chronic infections and lung damage, it has to be cleared. The traditional method is chest physiotherapy or CPT.
That involves percussion and vibration.
Yes, combined with postural drainage, positioning the child so gravity helps drain mucus from different lung segments while someone percusses or vibrates their chest wall to loosen it. It needs to be done daily, often multiple times a day.
That sounds intense. Are there alternatives?
Yes, thankfully. Things like high-frequency chest wall oscillation vests, basically a vest that vibrates rapidly, or devices like the flutter valve or acapella, which use positive pressure and oscillation when the child breathes through them. But some form of daily airway clearance is non-negotiable.
Okay, pillar 1, clear the airways. Pillar 2, nutrition. Why is that such a challenge in CF?
That same thick mucus blocks the ducts in the pancreas, so digestive enzymes made by the pancreas can't reach the small intestine to break down food, especially fats and proteins.
Leading to malabsorption.
Severe malabsorption. Kids with CF struggle to gain weight. They can have frequent, bulky, foul-smelling stools and vitamin deficiencies. So aggressive nutritional support is the second pillar.
How is that managed?
They need to take pancreatic enzyme supplements, brand names like Creon, Zenpep, with every single meal and snack. The dose is adjusted based on the food eaten and the child's response.
Enzymes of everything they eat.
Everything with fat or protein. And their overall diet needs to be very high in calories and high in protein, often 120–150% of the recommended daily allowance for their age, just to achieve adequate growth. Fat-soluble vitamins, A, D, E, K, usually need supplementation too.
Wow. That's a lot for families to manage daily. Airway clearance, enzymes with every meal.
It's a huge commitment. It requires incredible dedication and organization from the parents and eventually the child themselves.
Okay, we've covered a massive amount, from the tiny details of infant anatomy to the lifelong management of chronic diseases like CF. If you had to boil it down, what's the single most important takeaway for our listeners, the future pediatric nurses?
I think it comes back to vigilance. Understanding those anatomical vulnerabilities, the small airway, the compliant chest wall, the high oxygen demand, means you have to be constantly alert.
Don't wait for the obvious signs.
Exactly. Children compensate incredibly well right up until they suddenly crash. You need to recognize the early, subtle signs, the slight increase in respiratory rate, the mild retractions, maybe just restlessness or anxiety. Don't underestimate them. Recognizing that distress early, knowing why it's happening faster in kids, gives you that critical window to intervene effectively.
Seconds matter.
They really can. Early, astute assessment saves lives.
That brings us perfectly to our final provocative thought for today. We've talked extensively about the physical tasks of managing chronic respiratory conditions like asthma and CF, the daily CPT, the peak flow monitoring, the enzyme adherence, the medication schedules. It's complex.
Very complex.
But what about the psychological load, the constant vigilance, the disruption to normal life, the fear of exacerbations? This isn't just about teaching tasks, is it?
Absolutely not. The psychosocial impact on the child and the entire family is immense. Think about the daily grind, the time commitment, the financial strain sometimes, the social limitations. It can be overwhelming.
So the thought for you, the listener, is this. How do we, as nurses, move beyond just teaching the how-to of CPT or inhaler use? How do we effectively support families in integrating these demanding routines into their lives in a sustainable way?
How do we help them manage the stress, the fatigue, the anxiety? How do we empower the child as they grow to take ownership without feeling defined or imprisoned by their illness?
It's about helping them achieve mastery over the disease, not letting the disease master them. That requires ongoing support, empathy, and focusing on quality of life just as much as clinical numbers.
A really crucial aspect of holistic care in these chronic conditions.
Indeed. Something important to carry forward. That wraps up this deep dive into pediatric respiratory care. Really essential stuff.
Definitely. Thanks for joining us today.
We hope this helps. We'll be back soon with another deep dive into critical nursing content.